Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have as our guest today?
Today, from my home state of Michigan, we have, and from my alma mater, the University of Michigan, we have Helen Kales, who is professor of psychiatry, director of the Program for Positive Aging, and a research investigator at the VA Center for Clinical Management and Research. Welcome to the Jerry Pal Podcast, Helen.
Thank you, Alex and Eric. Happy to be here.
We have a really interesting subject to talk about today, managing behavioral symptoms seen in dementia. But before we do that, Helen, do you have a song for Alex to kind of lead us off with?
I do. I would like to hear Crazy by Gnarls Barkley.
Good luck with that one, Alex.
Yeah, not typically done on the acoustic guitar. Here we go. I remember when I lost my mind. There was something so pleasant about that place. Even your emotions had an echo in so much space. Does that make me crazy? Does that make me crazy? Does that make me crazy? Possibly. Eric's
all
like,
right.
Yes, you are crazy. You are crazy.
I was swaying in my chair.
I can't believe you pulled that off, Alex.
That
was great.
A little bit of practice. And it's like, maybe like 2% as good as the real song.
So, Helen,
great.
I really am super excited to have you on this podcast because, as you know, we've been working with a project with the Center to Advance Palliative Care, or CAPC, on teaching healthcare providers how to care for individuals with dementia and how to help their caregivers. And just a plug for that, anybody who has access to CAPC can actually look at the first 3 modules. But one of them was on this really common symptom that I always struggle with, which is the assessment and management of behavioral and psychological symptoms of dementia. And I did this huge kind of lit search to get ready for this module and to figure out what to put in there. And the one thing that everybody talks about is the importance of the DICE module, which I think was first developed in a JAGS paper that was published in 2014. And there was a follow-up BMJ article that you wrote. And then just recently in 2018, a great article on apathy also that came out in JAGS as well. And I was just hoping that we could chat a little bit about kind of how you approach behavioral and psychological symptoms in dementia. Would that be okay?
Absolutely.
Wonderful. Well, maybe before we do that, how did you get interested in this as a subject?
So back in the sort of 2010 era, I was doing a lot of work in pharmacoepidemiology and had done a lot of research looking at the risks of antipsychotics and specifically mortality. And as I went around the country giving talks, I found that people would raise their hand at the end of the talk and say, all right, well, what should we do instead? And I didn't like not having an answer.
Yeah, I mean, I give a lot of talks too. And I think the one biggest frustration is you keep telling us not to use these medications and no medications work. So what do I do?
Right. What
like
do
I have
we
this
do?
caregiver in front of me who's at their wit's end at home. They don't want to move this individual to a nursing home. The nursing home no longer wants to use antipsychotics for really good reason. Like, what do we do?
Exactly. And so it was around this time that I met Laura Gitlin, who's an absolute pioneer in the area of behavioral interventions, and she'd done several decades worth of trials with family caregivers. But as we talked, we found that a lot of those interventions never made sort of the research to dissemination, implementation gap. They never cleared it. And we were thinking a lot about why these methods aren't more utilized. Every expert panel always says, use behavioral interventions first. If you go and look in clinical settings, it's rare to really see those be implemented, and especially be implemented in an evidence-based way.
Can we just back up for a sec? And Helen, this is Alex, and I'm wondering what we're talking about when we're talking about behavioral and psychiatric symptoms in dementia. Are there specifics that are like, which are the most common and the most frustrating for patients, families, and clinicians?
Sure. So I think what clinicians often think of as behavioral and psychological symptoms are those that we commonly see in people without dementia. So depression, you may see agitation, specifically with, certain anxiety disorders. And people without dementia, you may see aggression or apathy, psychosis, certainly. But when you actually ask caregivers, a lot of what they have difficulty with don't fit neatly into any of those categories. And those are things like asking the same questions over and over again, maybe leaving the house, sort of exiting, wandering. It may be even things like resisting bathing. Mm-hmm. And so importantly, none of those things are good medication targets. And so our understanding of these symptoms is they're very heterogeneous. It's a very large group of symptoms.
Yeah, and the one that, it's interesting because the one that frequently comes to most physicians' minds, I think, when they're hearing about this is agitation. Mm-hmm. Agitation. Thinking about how we could potentially, help with that agitation, either the caregiver at home or the caregivers in nursing homes. Do you see that as a frequent, common problem?
So you've sort of hit a nerve with using the word agitation. I have a love-hate relationship with it. I certainly use it. But I liken it to, especially for internists like yourself, shortness of breath. So, if somebody comes in to a doctor and says, I have shortness of breath, you guys are going to do a history, a physical, you're going to do labs, and then you have certain algorithms that you're going to run through in your head, depending on, what some of those branches yield for you. And I should really think of agitation in the same way. It is not a disease. It's a symptom, just like shortness of breath. And it has different causes. The behavior looks the same, but the underlying causes can be, myriad.
Yeah, so maybe we should move into talking about the general approach. So
sure.
Yeah, first, maybe starting off with investigating the underlying causes, because I'm guessing the approach depends on the underlying cause.
Well, you're jumping the gun, Alex.
Am I jumping?
And this is why I really like the framework. Do you want to talk about that? Yeah. The framework that you came up with?
Yeah, absolutely. And so just to give you a little background on the framework, what we did was we then decided to hold this expert panel that in 2011, which included dementia care experts across the country, sort of across all the guilds, including geriatric medicine, geriatric psychiatry, pharmacy, psychology, social, etc. And we came up with the skeleton of what would become the DICE, but everybody sort of agreed on this algorithm, should I say, in terms of how they approach a complex behavioral problem or even a not so complex behavioral problem. And so the D stands for describe. And it's interesting that Alex didn't say it first, because most often skipped. So people jump to agitation, but that's really not a description. So if somebody calls you with agitation, your question should be, well, tell me more about that, because you really don't know whether that's somebody being anxious, somebody trying to leave the home, somebody yelling. You just don't even know what the manifestation is by the use of that word. And so you really want to know who was there, when was it, what happened, sort of antecedents, behaviors, and consequences kind of thing. But also importantly, is anybody at risk? Because that's going to change the metrics for you if, somebody is at risk, either the person with dementia or the person's. That's the first step.
So first step is to describe and get more detail about what is actually going on here when somebody uses like a generic term like agitation.
Yeah, and I really liked how when we talked, you kind of walked me through this, Helen, a ways back about how to think about the D. And I think you told me that you like to talk to caregivers and tell them, like, like to hear it played out like a movie. Well, how did you describe it again?
That's exactly right. And in our training, what we do is we tell them, think about how you would describe The Wizard of Oz to somebody that had never seen it somehow, like they were under a rock and they'd never seen The Wizard of Oz. And so the agitation way would be to say the witch died at the end of the movie. But if you were really going to describe that scene, you would put a lot of detail in about the flying monkeys and the castle and how the witch sets the scarecrow on fire and how Dorothy throws the pail of water and then the witch screams, "I'm melting." And so that gives you a lot more detail, and a person could really figure out why that was so exciting. And similarly, I think we want caregivers to give us that kind of detail about what's happening.
Yeah, and I also love the idea of like thinking about like, so they have these behaviors, like so what? Like what are truly the consequences? I think of wandering as something that we often see like in our nursing home. They may actually not be at it. I mean, they may be perfectly fine going back and forth between their room and the front, and it's great exercise for them. And I often wonder, like, okay, so what? This is great exercise.
Exactly, and that's part of it is who is at risk from this, and if there's really no risk, I think you have to change your calculation as to how it needs to be approached.
All right. So first up, we're getting a really deep, thorough description. So the D in DICE. Next step, we start antipsychotics?
No.
Or is this where we roll the dice? And how many sides are on the dice? Four-sided dice. And did you meet in Vegas when you came up with this?
No. It was actually, we thought, what could we, kind of like Siggy caps, what would be memorable for people? And, it was originally the 4D method, and nobody could figure out which D was which. So that wasn't going to work.
Okay. So I is not initiate antipsychotics. What's I?
No. I is investigate. And so, just like the shortness of breath example, we would want to figure out, where this particular symptom is coming from. And to try to make that a little easier for people, we think about a triangle of interacting parts in dementia, which is the person with dementia, the caregiver, and the environment. And the underlying cause could be coming from any one of those places or all of them. And so we try to think about things, the person, like could it be HEI, could it be constipation? We think about the caregiver because that's really important. Like when you were just using the example of wandering, that might bother some caregivers more than others. And it might bother certain caregivers because they themselves are depressed or they themselves are highly stressed. And so you want to think about those contributors to it.
So I really, and I learned a ton by talking to you, and I mean, it made me really think is that a lot of our training as like internists is the focus on the patient factors in this investigation. Is it a UTI? What can we do? Maybe we can educate the patient, like, which is always kind of strange because this person in front of us, has dementia. Like, how much education are you going to be able to do? And we ignore these other two huge factors, which is the caregiver and the environment. And if something is going to change, it's unlikely to be the patient. It's going to have to be the environment or the caregiver.
Well, and especially for caregivers, I mean, if we think about it, family caregivers get no education, no training by and large. They're given a diagnosis and they're supposed to, as you said a minute ago, soldier on. And, we really can train people how to communicate better, how to use improv in certain cases. Communication, a lot of people who aren't experienced handling they try to quiz people or confront them, dad is dead, mom, don't you realize that? Which is never effective because, the person has that belief. And so sort of challenging that in a way makes people more upset. And so I think teaching people sort of simple communication techniques, not giving too many choices at once, those kind of things. These are things that are fairly easy to do once people have the education to do it with them.
So what are some common environmental issues that you come across?
So The most common ones are related to stimulation, structure or activity. And I think, over or understimulation is really common. Understimulation, we see a lot in facilities where people may have nothing to look at or no activities. They may be sort of cranked in a jerry chair and, not have much to do. And they I think a response to be anxious or yell help is actually kind of understandable in those cases. In certain home settings, there may be overstimulation. People may be taking them out to family gatherings or parties, or they could be sort of have caregivers that are caught between taking care of grandchildren and taking care of a spouse. And so there's, clutter all around the house, children's toys, exercisers, and all that kind of thing. And so the person with dementia need to have a timeout.
Okay, so we've done D for describe, I for investigate. We got 2 more letters in DICE, C and E. So what does C stand for?
The C stands for create, and the create step is pretty much just limited by people's imagination. What we always tell caregivers is they know the person the best, so they can come up with the best creative solutions.
Mm-hmm. Some of the creative solutions we talked about in a previous podcast, we were wondering, is this ethical? Things like deception, for example, putting black tiles adjacent to the elevator entrances in nursing homes so that persons with dementia think, oh, I'm entering a yawning chasm. I don't want to fall off this cliff. I'm not going to get on that elevator.
What do you think about deception?
I choose not to call it deception. We call it stealth.
Stealth. That's a good reframing. Yeah. Other examples that come to mind of stealth?
There's an example we give in training where a person is arguing with another resident over a seat at the lunch table. And so the caregiver simply moves the person's tray over to communicate that that person should move to another seat without kind of calling it out and making it so obvious. Does that make sense?
Yeah. And in the Netherlands, they've actually sort of recreated whole environments like bus stops, etc., from like 50 years ago.
I just saw one of a picture of a person driving a fake bus and 2 people behind them like having a conversation, and they go in the bus
It's brilliant.
every day. Is it brilliant or is it lies, Alex?
I think it's kind. I actually think that, giving people an experience that they enjoy and that helps them to pass the time in a pleasant way is something that contributes to person-centeredness.
Mm-hmm.
So we're creating a plan, and these plans should focus on all 3 of those elements, right? The patient, the caregiver, and the environment, or potentially include all 3. Is that right?
Exactly right. So you're operationalizing what you found in the investigate stage. Mm-hmm. And, you want to manage, of course, any physical problems you find. But beyond that, you want to provide support to the family, to the caregiver, work on communication skills, and very importantly, create tailored activities.
Tailored activities. Can you say more about what you mean by tailored activities?
Sewing.
So a lot of...
No.
Well, yes,
That's
that could
tailoring.
be one.
That's tailoring.
But a lot of what we find in facilities, for example, is kind of one-size-fits-all activities where it's like everybody's going to sing this song or we're all going to do this craft. And what we try to tell people is by tailoring the activities to something meaningful to the person, that's the best kind of activity.
Yeah.
So we've done the D for describe, I for investigate, C for create. We're creating a plan that hits the caregiver, the patient, and the environment. We're done, right?
Exactly.
Nothing else?
Not yet.
Not yet.
Not yet.
We got an E.
Well, we always want to evaluate, and that's for a couple of reasons. I think you want to evaluate because we want to have people have some wins, right? So if you don't evaluate, it's easy to kind of move on to the next thing and say, oh, well, they're not wandering anymore, but now they're doing this. And it's really important to get a sense of how what people are doing is working or not working.
Yeah. So are there sort of specific techniques for evaluating? Is there like a 20 points questionnaire they should be filling out, or is it how does one evaluate?
So it can be as complicated or simple as one would want to have it. I think the neuropsychiatric inventory, the quick version, NPIQ, is one that people can do. It's one we use in clinical settings and in our trials. But for caregivers, it may just be kind of selecting on a numeric scale on 1 to 10, where 10 is the worst and 1 is the best. Kind of marking that a few times a week in a calendar, an appointment book, and sort of charting progress over time.
Mm-hmm.
Okay, so let's say, for instance, the DICE approach. I love it, especially when it comes to words like agitation, like really figuring out what do you mean by agitation, investigating where it comes from. How do you deal with things like apathy, which are like there's no oh, that was a period in time where they're apathetic, but rather it's been going on for months or years, where it's much harder to describe a specific scenario in apathy. How do you approach apathy? And again, I just want to put a plug for that JAGS article that you co-published this year, which I thought was absolutely fabulous.
Thank you. Well, I think with apathy, there's always something about these symptoms that, I guess I'm an eternal optimist, that's potentially modifiable. And if you think about people with apathy, often the trouble is in initiation. So it's hard for them to initiate an activity, but if you can help set it up for them and get them started, they'll be able to do it. So that could be one sort of creative strategy you could use.
Great. Where do medications fit? Is there a role for the antipsychotic here?
There's a role for medications. And so in the DICE approach, we have 3 scenarios where they're first line. One is depression that is significant either in the person, is not eating and they're not functioning, or they're suicidal. So we do believe in the use of antidepressants, particularly in early dementia, where the depression most represents that in people without dementia. Any particular antidepressant that we should consider, or all about the same? I think for the risk-benefit ratios, the ones we tend to use the most are citalopram or escitalopram.
Yeah.
And then the other 2 scenarios would be psychosis with risk. And why I say with risk is because in certain scenarios, like, for example, with Lewy body dementia, you may have people who are hallucinating, but the hallucinations are what we would call benign. They're not bothered by them.
It's that
so
deer
we don't want
in
to
the
treat those
corner
people.
that they actually like seeing.
Yeah, right.
Exactly. Well, we had one gentleman who was seeing he was seeing a kind of bookcase with Christmas decorations. It was like a display, and he loved it. And it was the family who was saying, take these hallucinations away. These are terrible. But he actually found it quite pleasant. So we talked to him about how these are probably transient. They'd go away after a few weeks. We don't want to increase his risk of things by adding something like an antipsychotic. So the third case would be aggression, where there's harm or risk involved. So you might say, well, aggression, there's probably always harm or risk, but that's not really the case, because sometimes the person might be a 90-pound person who's sort of sweating ineffectually. That's not really a risk.
Are there any other medications that we should think about when we are creating these plans around dementia behaviors?
Well, I'm glad you asked. We actually recently published a paper on a expert consensus panel, an international Delphi consensus in international psychogeriatrics. So I could tell you a little bit about that if you're interested.
That would be great.
So in that paper, we looked at both meds and behavioral approaches, and the behavioral approaches were, again, sort of the top recommendation. For medications, for BPSRL and for agitation, to use that word, it was citalopram and analgesia were the first line in terms of medications.
Pain medications.
Yeah, there was a nice study, wasn't there? Maybe you were part of this, I don't know, where they randomized patients to receive acetaminophen or in the nursing home settings, and dementia behavior symptoms were reduced.
Yeah, there was one on just acetaminophen, and the one everybody talks about too is the one that was a pain protocol where it's like 70% just got acetaminophen, but then the next step was like an opioid, and it ended up weirdly enough with like pregabalin. and
Wow.
behavior's improved. But again, the vast majority of people just got acetaminophen. So because pain is unrecognized a lot in these individuals and
Hard to diagnose.
Hard to diagnose, super common.
Yeah.
Pain is vastly underdiagnosed. And if you think about it, as people progress with dementia, they can't communicate to you that, their shoulder hurts or their knee hurts. So I think the cool thing about that trial was they just empirically treated people. They didn't try to discern whether they had pain or not. They did that empiric treatment and it worked.
Yeah, they included people with behavioral symptoms like agitation, but pain was not an inclusion criteria.
Right,
I love that study.
It makes so much sense. You think about the high prevalence of osteoarthritis in the elderly. Just because they have dementia doesn't mean they've forgotten they have pain.
Absolutely. And
didn't you write a paper about how arthritis was like one of the
more common? That was sort of at the end of life.
That was at the end of life.
At the end of life, not dementia.
But it's very common. I always think about a patient I had came in with the caregiver, and she said, "Dad is just ornery and stubborn. He wouldn't get into the car." And as I kind of went further, I examined him a little bit. He had a lot of guarding around his one shoulder, and we ended up getting X-rays, and he had a rotator cuff tear. And it was just astounding that, she was kind of attributing this to sort of negative, ornery stubbornness, when in fact the gentleman was in severe pain.
So I want to say a huge thank you for also talking with us today. If people want to learn more about DICE, or particularly maybe get more in-depth training, like how do they do it?
So there's some very good news there. They can go to our website, programforpositiveaging.org, and there we have upcoming, we have a website coming out where people will be able to get trained in the DICE approach.
That's great.
We'll include a link to that in the GeriPal post that accompanies this podcast.
Great.
Wonderful. And we also will be putting out a manual that accompanies that training. And so people can either get the manual separately or they can do the training. But we're really excited about the training because we're going to include some little sort of e-simulation videos of behaviors in there where people can kind of choose, make some choices and see what happens. And we're very excited about it.
And is this primarily training for clinicians, for physicians, for nurses, nurse practitioners, for caregivers? Who's the target audience?
Well, we're focusing on caregivers, and those would be either family caregivers or paid caregivers. But I always like to think that we're all in the same boat with behavioral training, because a lot of us in the medical field don't get trained in this in our own course of work, and so it could benefit anybody, I think.
Mm-hmm.
And I also want to say a big thank you for helping me out as we've developed the modules for CAPC. And also to our audience, if you're interested, we have about 7 modules, 3 of them up already, on ranging from disclosing a diagnosis to dementia to dealing with behavioral issues, mental health issues, symptoms, end-of-life issues. And I'm always shocked how many people don't know that they're CAPC members, but their institution has actually paid for CAPC. So if you don't know you're a CAPC member, just try logging in with your email account for your institution, and odds are you probably are one. So check that out. Again, Helen, thank you very much. Alex.
Thank you, Helen.
Do you want to end us off with a little bit more of
crazy? A little bit more crazy. Come on now, who do you think you are? Ha ha ha, bless your soul. You think you're in control? Well, I think you're crazy. I think you're crazy. I think you're crazy. Just like me.
That's great.
I want to also thank all of our listeners for joining us today. We look forward to talking with you next week. And also, if you have a chance, do us a favor. If you're listening to iTunes or any other podcasting software, please just take a moment and rate us and give us any feedback that you have. Okay, goodbye.
Bye, everybody.
Thank you.